Hello dear students, today our first lecture regarding removable and fixed orthodontic appliances. We will discuss about HOS technique, about dental velar anomalies, about etiology, cleaning and treatment methods. Orthodontics dental appliances gently force teeth to move through the supporting bone to a desired position. The purpose of the appliances is to correct tooth crowding, overjet or protruding upper tooth, deep overbite, spacing problems, crossbites and underbite or lower jaw protrusion. Orthodontic appliances can be classified as removable appliances, functional appliances, fixed appliances. Removable appliances can be taken out of the mouth by the patient itself. Functional appliances, which can be either removable or fixed, and fixed appliances which are attached directly to the teeth. Generally, removable appliances are used for simple tooth movement, such as individual tipping or limited expansion. They can also be used as an adjunct to fixed appliances, particularly during bite opening and molar distalization, or prior to functional appliance therapy to facilitate mandibular postural advancement. Functional appliances are used in the growing patient, often in conjunction with extraoral force to help correct both sagittal and vertical skeletal discrepancies, usually prior to the use of fixed appliances. At the end of the treating planning, the orthodontist should have a list of treatment aims and the strategy for their achievement. There are often several options available for any given malocclusion, including no treatment, and factors that may limit what can theoretically be achieved for any given patient should also be considered. A number of potential limiting factors will relate directly to the patient. Medical health, certain medical condition, dental health, excellent oral hygiene, and an absence of active dental disease are prerequisites prior to orthodontic treatment. Fixed appliances, in particular, can exacerbate dental problems. This does not mean precluding patient with a history of periodontal disease from treatment. However, the disease must be controlled and in a period of remission before treatment can be considered. If tooth movement is carried out in the presence of active periodontal disease, it will hasten bone loss. Age of the patient, growth can be utilized in adolescent patients to help correct a skeletal discrepancy. However, in adults, the orthodontist must rely upon tooth movement or surgery. A deep bite in growing individual can be corrected using a bite plane, which allows extrusion of the posterior dentition. In an adult, this is unstable because there will be no potential for compensatory growth at the condyle as the lower face height increases. Patient compliance, the success of orthodontic treatment, and is very much dependent on good patient compliances. A number of limiting factors will also be influenced by representing malocclusions. The more severe the skeletal discrepancy, the harder it is to correct with orthodontic tooth movement alone. Tooth movement to camouflage a severe discrepancy may be physically impossible or may result in an acceptable compromise to the soft tissue profile. This is especially true in class 3 malocclusion. Removable appliances are not permanently attached to the teeth and can be taken out of the mouth by the patient. During the first half of the 20th century, orthodontic practice in Europe was based largely on the use of removable appliances. However, over the past few decades, there has been a significant decline in their use, primarily as a result of more efficient fixed appliances being available and an increase in numbers of orthodontic specialists able to use them. However, simple removable appliances retain a place in modern orthodontic practice, usually as an adjunct to fixed appliance therapy or for use in the retention phase of treatment. In particular, a group of predominantly removable functional appliances used primarily in the management of class 2 malocclusion have enjoyed a considerable resurgence in popularity in recent years. In addition, new treatment systems using a vacuum-formed removable appliances, not only for retention but also for active tooth movement, have been developed. Let's consider the components of removable appliances. Removable appliances are composed of retentive and active components connected together by a base plate. When designing a removable appliances, consideration also needs to be given towards ensuring that the desired teeth will move under the active force applied by the appliances. The starting point for the design of any removable orthodontic appliance is deciding upon the desired tooth movements and how these will be achieved by the active components. Once these points have been addressed, consideration must be given to retention, encourage and connect all the components together using the base plate. Retention is a mechanism by which the appliance stays in the mouth and is provided by passive components such as clasps and labial bows. Good retention is important to ensure that the active components of the appliance are correctly placed and therefore effective. A retentive appliance is also easier for the patient to wear and therefore optimizes patient compliance. Encourage for a removable appliance is provided from either in an intro or extraoral source. Intraoral encourage comes primarily from the palate and dentition of the same dental arch, intramaxillary, whilst extraoral encourage is from headgear attached to the appliances. In certain circumstances, encourage is reciprocal when the planned tooth movement for active and reactive components are equal. However, the aim is often for specific teeth to be moved by the appliance with other remaining stationary. The active components of a removable appliance are responsible for producing the desired tooth movement. They can be categorized as springs, bows, screws, and auxiliary elastics. Springs mechanical principle should be considered when applying a force to any tooth with a spring. Screws can be effective for expansion, to correct a posterior dental crossbite, or for distal movement of the buccal segment, often supported by headgear. Each quarter turn of the screw activates it by approximately 2.02 millimeters and therefore should be done by the patient once or twice a week. Comprehensive orthodontic treatment is no longer undertaken with removable appliances alone because the results are invariably inferior to those produced by fixed appliances. However, removable appliances are relatively simple to use, generally well tolerated by patients, and can be used very effectively to correct minor occlusal problems, such as crossbites, in the mixed dentition, or provide a valuable adjunct to fixed appliance therapy. For instance, expansion removable appliances can provide an effective method for expanding the maxillary dental arch, particularly in the mixed dentition. The patient activates the appliance by turning a midline screw until the crossbite is overcorrected. The palatal cusp of the maxillary buccal teeth, occluding on the incline of the buccal cusps of the mandibular teeth. And following expansion, the posterior capping can be removed after a while, those ones, and the appliance worn at night for a period of 3 to 6 months as a retainer. Removable appliances are also effective at correcting an anterior crossbite. Palatal Z or T-spring can be used to correct 1 or 2 teeth in anterior crossbite, usually in conjunction with posterior acrylic capping, like you see here in picture, to open the bite and allow movement of the teeth out of crossbite. Occasionally, some anterior retention in the form of southern clasp may also be required. As you see, the clasps we need for retention of the removable appliances. Here we have Adam clasp, ball-ended clasp, this is base plate, and we need it for posterior bite plates when you want to open the occlusion. Most orthodontic treatment is carried out using fixed appliances directly attached to the teeth. Development of this appliance system began in the USA and the turn of the 20th century, and they have become progressively more sophisticated. Fixed orthodontic appliances are required for accurate tooth positioning. The brackets, arch wires, and auxiliary components that make up a fixed appliance are responsible for mediating tooth movement, and these take place at the tooth bracket interface. Fixed appliances are the most popular form of appliance currently in use today because they can effect complex three-dimensional tooth movements in the management of many different types of malocclusion. Dr. William Profit highlighted the importance of fixed appliances. He said that removable appliances by their very nature produce simple tipping movements of the teeth, making control of tooth position extremely difficult. And as a practical matter, it can be difficult to maintain removable appliances in place against the displacing effects. There is no orthodontist who does not recognize the name of Dr. William Profit and not read one of his books. His book, Contemporary Orthodontics, provides detailed coverage of orthodontic diagnosis, treatment planning, and treatment techniques. Key topics in this book include practical applications of computer technology, of modern digital technology, alternative treatment approaches, the biomechanics of orthodontics appliances, the treatment of complex problems in both children and adults. And I strongly recommend it to read these books for all beginners orthodontics. The predominant fixed appliance system in use today is based around a bracket with a rectangular edgewise slot and an inbuilt prescriptions for each individual tooth position. A number of modifications on this basis design now exist, largely concerned with the method of attaching the arch wire within the bracket slot and either positioning the bracket on the labial or lingual surface of the tooth. However, another group of fixed appliance, light wire systems, have also been developed, which allow much greater amount of tooth tipping during the early stage of treatment. I want to name the indication of fixed appliances. By the means of fixed appliances, we can do correction of mild to moderate skeletal discrepancy, intrusion or extrusion of the teeth, correction of rotation, overbite reduction by intrusion of incisors, multiple tooth movements required in one arch, active closure of extraction space or space due to hypodontia. And advantages of fixed appliances: they don't need the patient cooperation, use to treat the complicated cases of malocclusion, which we cannot treat by removable appliances, allow greater range of movement more than the removable appliances. And disadvantages, of course, they are more expensive than removable appliances. They allow accumulation of food around the appliances, that is worsens the brushing of the teeth, less aesthetic, need for special equipment, more complicated for doctors, and difficult to clean. The fixed appliances divided to edges system, bag appliances, tip edge appliances, and modern, we have now the modern fixed appliances, which arise from standard edgeless system, the contemporary straight edgeless system appliances. The standard edgeless appliance originated from the work of Edward Engel. Everyone now knows who is Edward Engel, the father of orthodontists, who experimented with a series of systems before developing the edgeless slot, on which most fixed appliances are now based. Initially placing the slot vertically, Engel found that by laying it horizontally within the bracket, greater control of the teeth could be obtained. The interaction of a rectangular wire in a rectangular slot providing precise three-dimensional control of tooth position. The standard edgeless appliance became the fixed appliances of choice up until the late 1970s. But it did suffer from several disadvantages. In particular, the passive bracket slot meant that final detailing of tooth position in rectangular wires was dependent upon many bends being placed within the arch wire for each individual tooth. This was time-consuming and required considerable skill on the part of orthodontists. The presence of these bends also meant that space closure had to be carried out with closing loops, which were also complicated to bend. In addition, teeth are are moved bodily along the arch wire through alveolar bone using an edgewise appliances, which is demanding upon anchorage. Here you see a later angle modified that ribbon arch appliance, in which they reorientated the slot from vertical to horizontal slot and inserted a rectangular wire rotated 90 degrees to the orientation it had with ribbon arch, thus the name edgewise. The dimension of slot was 28 mils or 28 mil precious metal was used. This is standard edgewise brackets, fully banded standard edgewise appliances with spaces closing loops in the upper and lower archways. By activating these loops, the doctors previously close the empty space after extraction. Bag appliances or light wire appliances was a modification of ribbon arch appliances in which Raymond Beck, Australian doctor, orthodontist, modified following things in the appliance. Australian orthodontist Raymond Beck he made an effort to overcome the high encouraged demand associated with the standard edgewise appliances and developed a fixed appliance system where tooth movement was based around the concept of differential force. The tooth crowns are initially tipped into their desired position using intermaxillary elastics. The roots are then uprighted as a separate procedure using auxiliary springs. It is much easier to tip a tooth than move it bodily, and this requires less force. So the Beck technique was much lighter on encourage and became very popular during the 1960s and 1970s. However, because it only uses round archwise, precise finishing is difficult, and the use of auxiliaries in the final stages of treatment to upright teeth that often have been tipped through quite significant distances proved to be quite complex, difficult to control, and also time-consuming. In an effort to address all of these disadvantages, the tip edge appliances was developed by Peter Kessling in the late 1980s. This appliance also tips the teeth during the initial phase of treatment, but allows later uprighting with more rigid three-dimensional control by closing the slot down around full-size rectangular archwise. After studying a large sample of untreated ideal occlusion, Lawrence Andrews, we know about the Lawrence Andrews as about his 6 keys of occlusion that we discussed in our previous lectures. Lawrence Andrews published his 6 keys of occlusion in 1972 and introduced an edgewise bracket system that has revolutionized fixed appliances orthodontics. The pre-adjusted edgewise or straight wire appliance that Andrews described is the most popular fixed appliances system in use today. Unlike standard edgewise brackets, which are identical for each tooth and require bends within the arch wire to generate individuality of tooth position, each tooth in the pre-adjusted edgewise system has a customized braces. This built-in prescription was based around Andrews' measurements from the untreated sample of ideal occlusion he studied and included a number of features. Preangulated slots for correct mesiodistal tooth angulation or tip, brackets bases inclined for correct inclination or torque, and variable distance from base of slot to base of slot to base of braces. To base of braces or to base of brackets for correct in-out position. In this pre-adjusted system, the work in accurately positioning the teeth is done by the bracket prescription, significantly reducing the amount of wire bending required. A further disadvantage is that it also allows groups of teeth to be moved and spaces closed by sliding them in unison along a rigid arch wire. Because one tooth alignment has been achieved, the arch wire sits passively in each bracket slot. The original Andrews bracket prescription is still available. Also, there have been adaptations made as the appliance system has been developed clinically. So Andrews described a pre-adjusted orthodontic bracket designed to control tooth movement in 3 dimensions, which required fewer bends introduced into the arch wire to manipulate tooth position. And all this, the buccolingual crown thickness, crown angulation, crown inclination of individual teeth from 120 study models were measured, taken from patients who had never received orthodontic treatments, and this value were averaged and their values incorporated into a bracket system designed to create his 6 keys to occlusion. Lingual appliances. One of the biggest problems associated with labial fixed appliances systems are the poor aesthetics. To overcome this, lingual appliance systems were introduced in the USA in 1970s. However, these proved to be clinically very difficult to use, and with the introduction of aesthetic labial braces, lingual orthodontics virtually disappeared from clinical practice in the USA. However, in Europe and Asia, several systems have been developed more recently, and the technique is growing in popularity. The principal advantages of lingual appliances are the improved aesthetics, lack of labial decalcification in cases with poor diet or plaque control, and better bite opening due to a bite plane effect of the brackets. Disadvantages for the patients include problems with speech, soreness of the tongue, and increased cost. Whilst for the orthodontist, there is the inherent difficulty and time required for chair side adjustment. Components of fixed appliances. The fixed appliances mostly consist from molar tubes, which are bonded directly to the tooth crowns, or in the case of molar tubes, often welded to stainless steel bands that fit around the tooth, arch wires, which are attached to the brackets and pass through the molar tubes, and auxiliaries, which will vary between appliance type, but include bracket ligatures, pins, elastics, uprighting and torquing springs, ligature wires, and fixed devices from encourage reinforcements of arch expansion. A significant disadvantage of metallic orthodontic brackets is their poor aesthetics. Edgeless bracket systems that are transparent or more closely resemble natural tooth color have therefore been developed. The early aesthetic brackets were made of acrylic and polycarbonate, which discolored quite rapidly and were prone to both permanent deformation and failure. To overcome these problems, plastic brackets were made in polyurethane or polycarbonate reinforced with ceramic or fiberglass fillers. Ceramic brackets were introduced in the 1980s and provide higher strength, more resistance to wear and deformation, better color stability, and superior aesthetics. They are manufactured from aluminum oxide, are described as either mono or polycrystalline, dependent upon whether they are made from one or many crystals. Although the aesthetics are significantly improved, they are not without disadvantages compared to metal braces. Ceramic brackets have low fracture toughness, which can lead to higher bracket breakage. There is also greater friction between the arch wire and bracket slot, which can be reduced by the incorporation of a metal slot. Excessively high bond strengths, particularly in the earlier brackets, also increase the risk of enamel damage on bracket removal. One final problem is the fact that ceramics are harder than enamel. This can result in significant enamel wear if brackets are placed in a position of occlusal contact with a natural dentition, commonly the lower incisors in cases which an increased overbite. Despite these problems, adult patients often request ceramic brackets because of the improved aesthetic. Self-ligating brackets. Friction between the bracket and the arch wire can theoretically result in the loss of anchorage and slower tooth movement. In addition, individual bracket ligation with conventional edgewise appliances is time-consuming for both patient and orthodontist. In an attempt to reduce friction and appointment times, a range of brackets whose slot is closed by the use of a metal gate or clip are now available. This technique is referred to as self-ligation, as the ligation system is built into the bracket. The concept is not new, having been originally pioneered in 1930s. However, these bracket systems have undergone a renaissance over the past 2 decades, largely because of enhanced ingenuity and reliability. Self-ligating brackets provide a number of theoretical advantages over conventional appliances. Because they reduce friction, more robust ligation, more efficient tooth movement and sliding mechanism, enhanced rotation control, and reduce chairside adjustment time. Arch wires. The original arch wires used in orthodontics were made of gold, but metallurgical advances have meant that a wide range of metal alloys are now available. These different alloys all offer a variety of physical properties which can be defined. The ideal properties required of an orthodontics arch wire will depend upon the stage of treatment and the type of tooth movements being carried out, and no arch wire material will offer all of this together. For this reason, a number of different arch wires are required during a course of orthodontic treatment, and this will vary in both the type of metal used and the dimensions. The particular sequence that an orthodontist chooses is often down to personal preference. Tooth alignment during the initial stages of treatment requires the following properties: large spring back, low stiffness, high stored energy, biocompatibility, and low surface friction. For this reason, round nickel, titanium, stainless steel, multi-strand or coaxial wires are generally used, and this will progress in diameter from 0,012 to 0,018 inches depending upon the degree of irregularity associated with the dentition. These are often followed by a short period with a rectangular nickel titanium arch wire to begin torque expression. Once initial alignment has been achieved, wires of increasing stiffness are used to complete the process of leveling the dentition, begin overbite reduction, and allow sliding of teeth along the archway. These are usually round stainless steel wires which provide the necessary stiffness over a range of diameters from 0,016 to 0,020 inches. During the later stages, the treatment, the process of overbite reduction is completed, and if necessary, space closure is carried out by moving blocks or individual teeth, either along the arch wire with sliding mechanism under force provided by auxiliaries, or with the arch wire under force provided by closing loops. For sliding mechanisms, the frictional properties of the arch wire will also have a significant influence on the efficiency of tooth movement, whilst for space closure with looped arch wires, good formability will be important. Arch wires used during the later stages of overbite reduction and for space closure tend to be made of rectangular stainless steel. Arch wire materials, the metal alloys currently used for the fabrication of orthodontic arch wires include stainless steel, nickel titanium, cobalt chromium, and beta titanium. Cobalt chromium, commercially marketed as alloy. Cobalt chromium has a greater formability than stainless steel and similar stiffness but with greater friction. It can be hardened by heat treating in the laboratory and is used for the construction of auxiliaries such as intrusion arch or quad helix. Nickel titanium or NiTi arch wires are characterized by high flexibility and the delivery of low force over long range. They also exhibit the phenomenon of shape memory. When deformed, they will tend to return to their original shape, and superelasticity, the wire delivering the same force over a large range of deformation. Beta titanium, introduced in 1890s. Beta titanium wires have good formability with a stiffness of around 1/3 that of stainless steel, but they are also associated with higher friction. These arch wires are used in the final stages of treatment, when finishing bends may be required to detail individual tooth position and achieve setting of the occlusion. A variety of auxiliary components are also required for the successful use of fixed appliances. These include both elastomeric and metallic products. Elastomeric products are commercially available and generally made from latex or polyurethane. This includes small elastomeric ligatures to hold the arch wire within the bracket slot, lengths of elastomeric chain, which can be stretched and used for moving single or multiple groups of teeth, elastomeric thread for the application of traction to individual teeth, elastomeric tube for covering exposed section of an arch wire, elastic bands for application of inter and intermaxillary force, and more robust extraoral elastic for headgear. Metallic products include lengths of coiled spring made from stainless steel, cobalt chromium or nickel titanium, which in an open configuration is described as push coil. Palatal and lingual arches consist of a rigid stainless steel wire soldered onto molar bands, like here in the picture. The orthodontist fits the relevant molar bands in the mouth, but does not cement them in place. An impression is taken with the bands inside, and they are transferred with impression to be cast up on the working model by the technician, who then constructs the relevant arch. The appliance is then cemented into place within the mouth. A transpalatal arch is constructed from 0.9 mm stainless steel wire that traverses the hard palate and is attached to bands cemented onto the first or occasionally second molar teeth. The arch fixes the maxillary intermolar distance, theoretically preventing these teeth from moving mesially into a smaller arch forms. Here, as you can see, we extract some tooth. You make distalization of first molars, and now we have to prevent their mesial movement by the means of the intermaxillary transpalatal arch. So we reinforcing their anchorage value. In reality, these arches are not particularly effective for anterior-posterior anchorage, but can provide useful vertical anchorage. When mechanically erupting an impacted tooth or using an intrusion arc. The palatal arc will also prevent maxillary molars from flaring buccally when using high pull headgear, and can also be activated to derotate molars. Nance, here we see the nance button, which lies on the palatal mucosa. This also acts to fix the upper arc length and can be used for encouraged support. However, these auxiliaries can cause soft tissue irritation if the acrylic button embeds into the palatal mucosa, especially if left in the mouth during overjet reduction. Lingual arcs are used in the mandibular arch and are also constructed from 0.9 mm stainless steel wire. The wire extends behind the cingula of the lower incisors and extends to bands cemented onto the lower first molars. Lingual arches are generally used as space maintainers, for instance, to keep the space after early extraction of primary molars. And so it maintained the leeway space during the transition from mixed to permanent dentition. fixed expansion arches, as you see here, are also fabricated in the laboratory and require a cast model of the maxillary arc incorporated in orthodontic bands for their construction in a manner similar to that of palatal and lingual arches. Here we see quad helix. It's made from either 0.9 to 1.0 millimeter stainless steel, or it can also be made from 0.95 millimeter cobalt chromium wire and extends across the palate from bands cemented onto the first molars, but also incorporates helix to increase the range of action. The quad helix is activated by approximately 1 molar tooth width and produces 300-400 grams of force, which gives mostly dental expansion up to 4 millimeters also in a pre-adolescent child, and it can produce some skeletal change. As you see here, the active elements are the 4 helical coils that activate upon adjustment to give lateral development of the arc. You should take initial measurements in the passive state, then after activation, apply orthoelastic on the appliance to its passive width for easy cementation. Here we take measurements and then after placing the elastic bands, returning in its previous position and easily place in the mouth. Also, the RME or rapid palatal expansion also can provide us with rapid maxillary expansion. Each turn of the screw is approximately equal to 0.25 millimeters, and it's turned between 2 and 4 times per day until the maxillary arch is overexpanded. This generally equates to the maxillary palatal cusp, occluding on the lingual inclines of the mandibular molar buccal cusps. And expansion here is mostly skeletal before the age of 16, when there is a patency of the mid-palatal suture. Following expansion, the appliance is left in place for approximately 3 months as a retainer. Up to 10 kilograms of force can be achieved with these appliances, and initially up to 80% of the expansion achieved will be skeletal, more so anteriorly. However, the longer term, a lot of this will relapse, with ultimately only around 50% being skeletal. Here we present the Pendex appliances, which are also the auxiliary fixed appliances for distalization of first molars. These pendulum attachments made by beta titanium by alloys, and it gives the distal movement of first molars. Both standard edgewise and bed brackets are simply placed at a specific distance from the occlusal edge of the tooth crown. However, this does not provide a consistent reference point, and the bracket position is determined primarily by the size of crown. With contemporary pre-adjusted appliances, the aim is to place the bracket at the center of the anatomical crown and parallel to the long axis of the tooth. This means that the bracket prescriptions will be expressed correctly in relation to mesiodistal tip, torque, and in-out position, irrespective of the size and form of the tooth. Bracket positioning can be achieved in two ways. Direct bonding places the brackets on the teeth individually at the chair side, and indirect bonding places the bracket on study models in the laboratory, and these are transferred to the teeth using a positioning tray. The advantage is greater accuracy of bracket positioning. However, the extra cost and time involved make this process less popular for routine orthodontics with labile appliances, although it is used when placing lingual fixed appliances. As you see in these pictures, you see direct bonding. Orthodontic brackets are generally bonded to enamel using mechanical locking created by acid etching the enamel surface of the teeth. The steps involved in bonding are as follows: cleaning the tooth surface to remove any pellicle using a slow hand piece and profi brush or cup, acid etching the enamel surface using 37% phosphoric acid for 20-30 seconds, washing and drying the tooth surface, placing and filled primer on the edge area of the tooth, placing composite resin on the bracket base, positioning the bracket on the tooth crown, cleaning up excess composite from the bracket around the bracket base, and curing the composite either chemically or with glue. Right source, and it is very important to clean up excess composite or flash, because it can create problems in maintaining high levels of oral hygiene and result in demineralization around the bracket, a major risk of fixed appliances therapy. This is indirect placement of braces. Removable of appliances. Bands are removed using special pliers which exert an occlusal directed force from the gingival margin. Because of the anatomy of molar teeth, the force is applied from the palatal aspects in the maxillary arch and buccally in the mandible. In contrast to bands, the bone strength for bondable attachments must be higher to prevent repeated failures. The aim upon removal of bonded fixed appliance is for the failure to occur between the bracket base and composite junction, and not at the junction between enamel and composite, to avoid the risk of enamel fracture. To achieve this, a shear force is applied across the bracket base with the bonding pliers. This distorts the bracket base and causes failure at the junction between bracket base and composite. Residual composite is removed from the tooth, ideally using a tungsten carbide fissure bore in a slow handpiece. Ceramic brackets initially had very high bond strength, which result in a significant risk of enamel fracture or debonding. To overcome this, most contemporary systems have a failure point built into the bracket base, which means that when a shear force is applied, the bracket fractures down the midline, collapsing the tie wings of the bracket that can be easily removed. So you can say that Dr. Edward Hartley Angle, father of modern orthodontics, contributed not only to classification, diagnosis, but also to develop new orthodontic appliances. In 1987, he created the angle system, which ultimately would result in the introduction of the edgewise multi-banded appliances in 1928. With few exceptions, the contemporary edgewise appliances based on Angle's design from early 20th century. And also, it is very important that Andrews, who describes several different bracket series for extraction and non-extraction cases, in addition to series for use with different amounts of crowding, include adjustment for tip and rotation to counter the effects of space closure. But overall, these different series significantly complicated stock management for the orthodontist. And in contrast, Ronald Roth recommended a single series based on the Andrews extraction prescription. And that these prescriptions we use all over the world nowadays. And it's very often used in our republic also. This prescription had extra torque in the upper labial segment because the edgewise slot does not express the full torque value of the bracket, particularly as the upper labial segment is retracted during space closure. Roth also placed a greater emphasis on functional occlusion and gave the canines greater tip to facilitate cuspal guidance. There was also greater torque in the maxillary molar region to prevent dropping of the palatal cusp and eliminate non-working side interferences. More recently, Richard McLaughlin, John Bennett, and Hugo Trevisi have developed the MBT prescription, which has increased torque in the upper labial segment and lingual crown torque in the lower labial segment. This was designed to minimize proclination of the lower incisor during treatment, and the MBT prescription also has reduced tip, most notably in the upper arch, to reduce anchorage requirements. In addition, reduced torque in the lower molar region helps to prevent lingual rolling of lower molars as they are moved along the arch wires. Thank you for today's lectures, and in our next lectures we will discuss the treatment of different malocclusions like class 2, class 3, and malocclusions towards the vertical and horizontal plane.